So yes, my name is Jannik. I hope you can hear what I say, and you can hear that I talk with an accent is correct. I am from Denmark. First of all, thank you for inviting us. Thank you for setting up this meeting, this wonderful festival. So thank you for the Congress Committee for that. And to all of you sitting behind computers and listening into our talk, thank you for participating. I represent Medclair. Medclair is a Swedish technology company. We develop technologies for safe and zero emission from nitrous oxide. And I think that's important. This is what we're going to talk about. It's the molecule of nitrous oxide mixed with oxygen. You might know it as gas and air. You might know it as Entonox. I know it as Levopon. It's a matter of brand names in different countries. But anyway, thank you for participating. And here with me, I have Angela. Angela.
Hi, I'm Angela Owen, and I work for a company called BPR Medical. We're a medical gases therapy company. We sell medical gas equipment. I've been in business for about since 1990, and I'm a business manager with the company. And we are now working in collaboration in the UK with the company Medclair, the technology company, with our inhalation device, which is called UltraFlow. So that's a device which is for the analgesic gas to flow through into the mobile destruction unit, and that focuses on the patient side.
So a little bit of background, and usually I start these presentations, and I've done this for 13 years. Usually I start these presentations with asking midwives, saying, okay, this is, let's say that this is the pharmaceutical brand name. It's called Entonox. I usually ask the question to the crowd, how many of you have actually read the product resume on it? And I'm an ICU nurse myself, so yeah, I read the product resumes, and I mean, that would also be the take-home message for you today, if you're going to be working with this, and I would expect that you do, because when we look at some of these studies where we have to ask midwives on an international scale, how many patients do you actually offer this to, we come up as high as 80% of patients saying, hey, yes to it. So please, I encourage you now to go home and read up on the product resume on Entonox. Contraindications, side effects, and stuff like that, right? The reason why I think you should do it is that we do things differently in Scandinavia. And you can hear that I have this accent, right? We do it differently. So we do it like you do on the inhalation side. And the inhalation side, you use technology from you, Angela, and what does that do? So
it's a demand valve, so it's a demand-driven system. This is the actual device we're here exhibiting today, so we're lucky just to have the device with us. But it's a complete unique system that allows you to scavenge the gas into the mobile destruction unit via a diverter system. So it's a closed system rather than an open system.
But you can do great things. I mean, you're a midwife, and this net zero target that is now with the NHS, you as midwife can do great things on it. And just to give you a little bit of example of this net zero, it's all about, okay, what do we do as a private person? I bought myself a hybrid car. I'm now also selecting my waste and, trying to separate it. I try to do whatever I can do. You can do great things, because the thing about Entonox is that it's a greenhouse gas, right? It's a heavy greenhouse gas. And if you look at this slide here, do we have the slide up? Is the slide up? All right, good. If you look at this slide here, you can see that anesthetic gases comes out with 5% of the admission. And this is with you. I mean, the nitrous oxide program, the Entonox program, that's with midwives. You are the power users. And when I say power users, I also know that Angela and her team support children departments, emergency department, orthopedic departments. We do the same thing in Denmark, but they're not power users. You work in settings where there is an extremely high flow on inspiration. If I now put myself in any place in a hospital and try to see, hey, where are there any patients that really moves air, meaning that they expire extremely heavily, it's with you. I mean, you're the ones that really deals with these ladies in severe pain. And with severe pain comes this thing about pushing air in and out, in and out. that leads to two issues. I'm not going to call them problems, because I don't think they're problems, but you have two issues. Two issues, right? That you work with Internox, and with Internox, we do talk about the zero admission, but we also address, of course, staff safety, exposure to staff. And that's going to be an important take-home message, I think, also, is that please now go home, or you that sit at home with your computer, go into your daily work and see what kind of device do you actually use for inhaling the gas. And more important, what happens with the exhaled gas? Where does that go? When I'm in Scandinavia, we always, and I really stress it, we always collect the exhaled gas and remove it. I have never been in any hospital in Denmark, Sweden, Finland, Norway, and seen an open system. And with an open system, I mean that you, of course, inhale through this device that Angela showed you on the exhalation where they exhale back. And this is going to be a powerful thing. They really exhale back powerful. Where's that going to go? The NHS needs your support. Because if you do it like we do it in Scandinavia, where we collect the exhale gas and remove it away from staff, it's going to be possible for us to destroy it and have zero admission. I hope you see that this will also do something good for you. Work safety. So when we do talk about this in Scandinavia, it's not really a concern, collect and remove exhale gas. We do it. So to all of you listening in, I encourage you now to go home, go into your midwife department and see if you collect exhaled gas today. And if you don't, then call BPR Medical and ask for their service and expertise, because this is gas expertise and you have it. Correct me if I'm wrong, Angela.
We do definitely. Yeah, so the device has been in production since 2008, so it was designed with a panel of clinicians and midwives and medical engineers. We consulted everyone to design it, and the gas scavenging was part of the design. So we knew at that stage it was very important to be able to have a diverter that would allow you to scavenge the gas. In traditional systems that are currently available, the gas is still scavenged, but it is vented to the atmosphere. So this device now is groundbreaking, because it will allow you to scavenge the gas and not only keep you safe, but it will also protect the environment too.
And think about it, this thing about, okay, the 5% that we just showed on the slide, this NHS, the 5%, how much is that really? I mean, this thing about giving birth to a baby using Internox, what are we talking about? What's the equal balance in CO2 emission? It's like putting yourself in a car and driving 1,400 to 500 kilometers in a car. 4 hours of intimate use of Internox. So this is really something that is powerful. And if you see how does the NHS really start to calculate this, they say, hey, 1 kilo of N2O is equal to 298 kilos of CO2. So you guys, you ladies, you can really do great things here with the NHS. And you don't need a lot of things, happening in your daily work to do it. I mean, basically what Angela here is showing you is that you connect an exhalation hose to your current device. And then the exhale gas needs, of course, to go somewhere, right? Needs to go somewhere. So where do we suggest that it goes to? I think you have seen some of these. Maybe you have seen some of these pictures. This is something that is already occurring in some hospitals here in UK. I know there was a great story with the BBC, because Newcastle a couple of months ago did first baby zero.
That's right, yes. There was the first net zero baby born. Baby Rosie was born there, I think it was in September time. And the midwife that delivered was the first person to actually use the machine. So she was absolutely thrilled to be able to use it for the first baby, and the whole team over there were really really excited about being able to use the technology.
And that's where we want to go, right? I hope that you see here on this slide that we have created a system where we work now with two things. The one thing we don't work with in Scandinavia, because we already do it, is this thing about capture the exhale gas and removing it. We're doing it. I mean, totally impossible for us not to do that. So we're already collecting it. In some hospitals, and Medclair is a Swedish company, so I'm not going to say some hospitals, I'm going to say all hospitals, because the technology to destroy nitrous oxide, Internox, is not a new technology. This is something that has been going on in Sweden for 12 years. So if you now come to Sweden, and please I encourage you to go as a midwife and visit some of these Swedish hospitals, you will see that all the exhale gas is captured. And it's removed over to a unit called an AGS unit. It's a connection. And hospital technicians, if you call them and say, hey, what's an AGS connection? We have all, we participated in a festival, and there was this Danish guy talking about an AGS connection. They know it, because anesthetic doctors use exactly the same system, because they work with extremely powerful agents. So if they're exposed to it, they fall asleep. So on the back of the anesthetic machines is a hose that goes over to an AGS outlet. We're back in Sweden. They use the system, right? So they capture all the exhale gas and they remove it over to an AGS system. All these rooms are connected up to one single unit, one single destruction unit. So let's say that a Swedish hospital has 15 delivery rooms. They will then have AGS outlet in all rooms, and in all of those rooms are then connected up to one central destruction system. We heat up the gas, and by heat we split it into nitrogen and oxygen. This is room air, and that's what we leave behind. And this is exactly what the NHS is now focusing on, but they need, of course, your help, right? Because they need midwives to collect the exhale gas. And why shouldn't you? I mean, it's a good thing for you as well, right? It will also improve your work environment. If you don't, and this is the case with these hospitals that we work with today, if you don't have an AGS outlet, okay, how do you do it? How do you then destroy? You cannot have, you don't have the AGS outlet. We also have this technology as a mobile technology, a small scaled device. Same technology, but just made mobile. So that is exactly what Newcastle did.
Yep. So, yeah, they used the mobile unit, they used the ultra-flow demand valve to deliver baby Rosie. It was easy to use, wheels to the patient, it was easy to connect up, and yeah, the patient said she felt really comfortable using it as well. So there was good feedback from the mom as well.
But that's also how we do it, right? That okay, what does this device need? It needs electricity. The big device also works on electricity. The small device, same thing. So you plug it in to power, you turn it on, and it heats up. And as soon as it's warm enough, it tells you with a green light. It's not a sophisticated device to work. There's an on and off switch. So as soon as it's warm enough, it will tell you by a green light. And now it's just a matter of, hey, how good are you as midwives on collecting the exhale gas and removing it over for destruction? That's as simple as it gets. And I mean, you can really move a lot, because think about it. Think about how much Internox gas and air you really use throughout a baby delivery, right? So this is what this system does. It's all about plug in, play, turn it on, make sure that this is, the device that you use. I encourage you that are here, thank you for coming, and those sitting behind the computer, to really go into what kind of inhalation device do you use today. I mean, I see some of you being young midwives, you're going to be working with this, for a long, long time. And thank God it really helps a lot of women, right? Because you're kind of limited to what pharmaceutical you can use. I mean, I'm an ICU nurse. I had all the pharmaceuticals in the world to play with because I did not have to think about a baby. You need to think about a baby because of that, you're kind of limited to how many pharmaceuticals you have to play with. So this is what we do, right? This is what you do. This is what you can do. So if you have one of these MDUs, the mobile technology in place, and you work with it, how much are you really removing, equal to cars? And this is what the NHS is really also talking about. Hey, how much are we winning with this technology? Well, the Swedes did it 12 years ago, and why did they do it? Of course they did it because they knew that this is going to have an impact. So one MDU up and running with midwives collecting the exhale gas from the women, removing that gas over to one of these MDUs is equal to removing 275 cars off the road. So you ladies can really make an impact. But of course you need now to raise the voice and say, hey, the NHS, we know about it, we will focus on it, give us access to technology, right? Give us access to the technology. It's not complicated to work on the device that Angela is showing you, saying connect an exhalation hose and guide this away from us. And then the technicians coming and support you with the rest, basically. So this is happening as we talk today. Hospitals and trusts are calling us, setting up meetings. We do talk with a lot of sustainability people. We do talk with a lot of anesthetic doctors. We sadly do not talk a lot with you, midwives. And I think that's a shame, right? Because you are going to be the one with the power to make those 5% go away. If you start now to come home and say, we will now commit, we will support the NHS to these 5%, we will make it happen, just give us access to technology and we can make it happen. Why shouldn't you do it? Why shouldn't you do it? What's the I'm an ICU nurse myself, and every time something new came into my department, it was always, hey, what good can this do for me? It can do great things for you. Absolutely. If you come into your department today and you see, hey, there's the inhalation device, where's the exhalation going? Is it just being blown out to the room? If that happened in any Scandinavian hospital, they would say, not really an ideal thing. Because I'm a midwife and I need to focus on to patients, right? The mom and the baby. So it might be that this is a fun job, but I will find it being amused on something else, not being exposed to exhaled internox. So that's also the key message, I think, to the audience here is to really go back and start asking the questions. The 5%, you can do it easily. I mean, Sweden did it 12 years ago. Denmark is doing it. Norway. You can do it, absolutely. This is happening, right? So a lot of hospitals, a lot of people are calling us. I encourage you as midwives to now go back to your department and find the phone number to Angela and her team, right?
Yeah, absolutely. Yeah, contact us if you need any information on exposure or safety, or obviously Jannik mentioned how many cars this can take off the road in terms of sustainability for your departments, and obviously keeping your mum safe, keeping you safe and the team. It is really fantastic technology, and it's doing great things for the environment. When you think about the amount of CO2 that is emitted, from the gas in the hospital, it really can make a difference.
Take-home message. I hope you find it beneficial to come in here. take-home message will be, please go home, please, look into what kind of inhalation, exhalation device do you use. Please, address this to whoever has the interest and power to make things happen. Call BPR Medical and ask for their expertise on it. You can make things happen, and this will be the mission that midwives can really engage into, the 5%. You can remove them. I mean, I have no doubt about it that you can start to collect that exhale gas and guide that over to a technology for destruction. And why shouldn't you, right? It will also improve safety for you. I think we have time for questions, right? We're on a time slot here. So 12:05, any questions from the audience? Please feel free. Great question. Thank you for that. So currently in Denmark, I'm going to give you a practical example, right? Currently in Denmark, we have the biggest birth department. They have 7,000 baby deliveries per year. So it's a pretty good sized birth department. They have 15 rooms. They started out with AGS outlets. So there are AGS outlets in each and every room. Why do they have AGS outlets in each and every room? They have it, and this is back to my first question to you, read the product resume. Because in the product resume, it states that you need to have scavenging or good ventilation. What is good ventilation? Is this good ventilation? I have no idea. Scavenging means that you collect the exhale gas and you remove it to an AGS. All these 15 rooms in this hospital are now connected up by a pipeline, each and every room, one single pipeline that goes out to the big unit. Big unit. What do they do in rooms where they don't have AGS outlets? The small unit, right? The small unit. But the hospitals that we do talk with today, they're not investing in 15 units all of the time. They're saying, hey, give us a couple of units, a couple of these small mobile units, and we will see how good our midwives are in collecting the exhale gas and destroying it. By showing that, they will find the money for the outlets in each and every room. Thank you for the question. I hope I answered it okay.
I was wondering, taking chance, can you do something like try before you buy? Because I look at that machine, it looks, the little one, it looks very neat, and I can imagine that in a labour room and thinking, that's handy because if another woman needed it, you've got it on mobile. But a try before you buy I'd be interested if I was anything, just to try it.
That's a great question. And we have done several trials in the UK. And certainly some of the larger trusts have also done some testing with it too. So they're testing the actual demand valve delivery system, and they're testing the MDU. And one of the medical engineering team and the Manchester University Trust has written a paper, a science paper on it, to show how it works. So the technology itself works. So we have done those trials, and there have people that have already trialled it. So it is a proven system. But yeah, we'd be happy to talk you through anything that you needed for your team. Yes, definitely.
Finances are always
yes, definitely.
All right, if no more questions, thank you for participating and thank you for coming in and listening. I really enjoyed it. Thank you.